Good afternoon. My paper is on assessment of dry eye using a comprehensive dry eye evaluation tool. I have no financial interest. DUCE 2 defines dry eye disease as a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, neurosensory abnormality play etiological roles. Mainly, two forms of dry eye disease are recognized. They are the aqueous deficient dry eye and evaporative dry eye. These two forms can present as single entities or they may overlap, causing a mixed type of dry eye also. In aqueous deficient dry eye, there is reduced lacrimal secretion in conditions of normal evaporation from the eye, whereas in evaporative dry eye, there is excessive evaporation from the exposed tear film in the presence of a normally functioning lacrimal gland. Our aim was to study the prevalence of various subtypes of dry eye disease in a hospital-based population and to analyze it according to the pathological subtypes and also to study the various risk factors. Ours was a cross-sectional study and we included patients above the age of 18 years who reported with symptoms related to dry eye and who were advised dry eye evaluation. Those with acute ocular surface infections, extensive ocular surface pathologies, ocular surgery within the past 2 months were excluded. We took a detailed history. Symptom score was assessed using both OSDA and DEQ-5 questionnaire. Clinical examination was followed by a comprehensive dry eye workup, which included assessment of tear film and meibomian gland using non-contact, non-invasive IDRA ocular surface analyzer, tear volume assessment using both Schirmer 1 and 2 test, ocular surface staining using fluorescent and lysamin green to assess the extent of ocular surface damage, lip post and lid viper epitheliopathy grading. Tear film analysis using IDRA measured non-invasive breakup time, meibomian gland loss area percentage of both upper and lower lids, lipid layer thickness, tear meniscus height and eye blink quality. And finally, patients were classified according to the type and severity of dry eye. Moving on to the result, we enrolled a total of 231 patients and majority were females and the mean age was 53.02 years. Evaporative dry eye was the most common subtype followed by mixed dry eye and majority of patients had moderate severity of dry eye. And all the three subtypes of dry eye occurred predominantly in females and the predominant symptom reported by patients were feeling of dryness followed by itching and burning sensation. On analyzing the symptom severity score, we found that about 66.2% of patients had a normal OSDA score, whereas about 64.9% of patients had a DEQ-5 score of more than 6, which was suggestive of dry eyes. On analyzing the risk factors, we found that about 50.2% of patients used visual display terminal for an average of more than 4 hours, of which more number of patients were in the age group of 18 to 45 years. Evaporative dry eye was the predominant type and incomplete blinking was noted in 60% of patients in this age group. On tear film analysis using IDRA, we found about 76.2% of patients had an NIBUT, that is non-invasive breakup time of less than 10 seconds. 74.5% of patients had lower values of lipid layer thickness and lowest values of lipid layer thickness was found in patients with mixed dry eye. About 59.7% of patients had lower values of tear meniscus height. Patients with evaporative dry eye had more area of meibomian gland loss followed by mixed dry eye and about 67.1% of patients had incomplete blinking. On correlation analysis, we found a positive correlation between OSDA score and meibomian gland loss area and a negative correlation between OSDA score and tear meniscus height. Moving on to the discussion, in a study conducted by Lemp et al., evaporative and mixed dry eye accounted for about 80% and only 10% was aqueous deficient dry eye. A similar distribution was seen in our study also. In another study conducted by S. Chatterjee et al. On OSDA and DEQ-5 score comparison in Indian patients with dry eye disease, they found DEQ-5 scored symptoms higher than OSDA questionnaire. In our study, we found number of patients diagnosed with dry eye disease using DEQ-5 questionnaire was higher than using OSDA questionnaire. In another study conducted by Woolson J.S. et al. On risk factors for dry eye disease, they found that greater digital screen exposure was found to be a predictor for evaporative dry eye. In our study, in about 60.8% of patients with evaporative dry eye, there was a reported usage of visual display terminal for more than 4 hours. In another study conducted by Wei Feng et al. On morphological changes in the meibomian gland using infrared mammography, they found a large proportion of meibomian gland dropout cases among patients with dry eye disease. In our study, about 64.5% of patients had a meibomian gland loss area of more than 40%. So to conclude, there is a high prevalence of evaporative dry eye with a female predominance in all the 3 subtypes of dry eye. DEQ-5 questionnaire was found to be more sensitive for assessing symptom severity compared to OSDA score. Visual display terminal use for more than 4 hours was found to be an independent modifiable risk factor for evaporative dry eye. Positive correlation between OSDA score and meibomian gland loss area and a negative correlation between OSDA score and tear meniscus height indicate that loss of meibomian gland and poor tear meniscus height are directly associated with dry eye symptoms. These are my references. Thank you.
The study was done as a questionnaire or physical examination?
Physical examination.
With the questionnaire also?
Yeah. With both OSDA and DEQ-5 questionnaire and also physical examination.
But the age is varying from 18 to 88. Age-wise, have you done any analysis? Age group?
No.
No, because 88 and 18 has no comparison. That's why.
Sir, we included the patients who reported with symptoms of dry eye. Those came with symptoms of dry eye.
18 age people are also coming with a dry eye?
And also,
with the computer vision syndrome, anything? What is computer vision syndrome?
Computer vision syndrome.
Usually 18, 20 means usually will...
seen in more patients who are using visual display terminal for more hours.
Have you done an analysis based on occupation of the patient? Any analysis? Especially evaporative. Those are sitting in this room are more dry eye. Those are sitting in the air hole. Because air hole has good AC, here has no AC. So
occupation wise we didn't, but we analyzed what type of visual display terminal they are using and how many hours they are using.
Okay, good.
The evaporative dry eye common in females, you noticed. And is there any females? And they are working group or not?
Occupation we didn't analyze.